Welcome to this Step 3 clinical knowledge review on chronic disease management for diabetes and high blood pressure. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for diabetes and high blood pressure, and teach you strategies to pick the right answer quickly and confidently. The goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the diabetes and high blood pressure sections of your main board review book and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for diabetes and high blood pressure. Next, we will apply specific strategies for questions about diabetes goal setting, medication titration, and the stepped approach to blood pressure. Then we will master the next best step question format for monitoring, complications screening, and deciding when to refer to a specialist. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the diabetes goal-setting split. When you see a diabetes question, before you pick a number, ask who this patient is. The exam wants you to match the hemoglobin A1C goal to the patient in front of you. A younger patient with few other problems and a long life ahead points toward tighter control, with a goal below 7%. An older patient, someone with a history of dangerously low blood sugar, advanced complications, or limited life expectancy points toward a looser goal around 8%. The trap is choosing one fixed number for everyone. Read the patient first, then set the goal. Strategy 2 is the stepped approach to high blood pressure, and the boards test this in many ways. For an uncomplicated patient, your first-line choices are a thiazide diuretic, a calcium channel blocker, or an angiotensin-converting enzyme inhibitor or angiotensin receptor blocker. Here is the key move. When the blood pressure is far above goal, the exam expects you to start 2 agents together rather than one. The other half of the strategy is the compelling indication. The right drug is often hidden in the patient's other conditions. Diabetes with protein in the urine points you to an angiotensin-converting enzyme inhibitor. Heart failure with reduced function points to specific guideline-directed agents. A Black patient without those conditions points toward a thiazide or calcium channel blocker first. Read the whole patient before you choose the drug. Now let us go through high-yield stem recognition. For the diabetes titration stem, the patient is already on metformin and the hemoglobin A1C is still above goal. Look for clues about heart disease, kidney disease, or weight, because those clues choose your next agent, and metformin almost always stays on board. For the hypertension combination stem, the blood pressure remains above goal despite one agent at a good dose. The right answer is usually to add a second agent from a different class, not to maximize a single drug or simply recheck later. For the complications screening stem, you have a stable diabetic at a routine visit, and the question is really asking whether you remember the yearly checks, an eye exam, a foot exam, urine protein, and a kidney and cholesterol panel. These 3 stems repeat over and over, so learn to recognize them on site. Let us work through our first practice question. A 58-year-old man with type 2 diabetes and known heart disease has been taking metformin for 1 year. His hemoglobin A1C is 8.1%. His kidney function is normal, and he is overweight. What is the most appropriate next step in management? Take a moment to think about which detail in this stem is steering the answer before we walk through it on the next slide. Let us break this down step by step. Step 1. Spot the pattern. We have a diabetic on metformin, a hemoglobin A1C above goal, and the stem highlights established heart disease. That detail about heart disease is exactly what the question wants you to notice. Step 2. Apply the rule. When a diabetic with heart disease needs a second agent, choose one with proven heart and kidney benefit, such as a glucagon-like peptide 1 receptor agonist or a sodium glucose cotransporter 2 inhibitor, and keep metformin on board. Step 3. Eliminate the wrong answers. Stopping metformin and jumping to insulin is too aggressive here. A sulfonylurea gives no heart benefit and risks low blood sugar and weight gain. Continuing metformin alone leaves the patient above goal for too long. The correct answer is to add a glucagon-like peptide 1 receptor agonist. Here is our second practice question. A 60-year-old woman with type 2 diabetes has a blood pressure of 150/90, despite taking a maximum dose of lisinopril for 3 months. She takes her medication reliably. Her kidney function and potassium are normal. What is the most appropriate next step? Think through this one carefully. The key detail is that she is already on a full dose of one agent, and she is adherent. We will walk through the answer next. Let us work through this answer. First, read the question carefully. The STEM tells you she is reliable with her medication and already on a maximum dose of one agent. That detail rules out poor adherence, and it rules out simply waiting and rechecking. When one drug at a full dose is not enough, the board answer is to add a drug from a different class. Now, why does adding a second agent win? Pushing the same drug even higher gives little extra benefit and more side effects. Switching to a beta blocker is wrong, because it is not first line here and it abandons a drug that protects her kidneys in diabetes. Waiting another 3 months just leaves her uncontrolled. The correct answer is to add a thiazide diuretic or a calcium channel blocker. Let us review monitoring and complication screening, because this comes up constantly. For diabetes, check the hemoglobin A1C about every 3 months until the patient is stable, then twice a year. Every year, screen for eye disease with a dilated eye exam, check the feet for loss of sensation, and test the urine for small amounts of protein. The exam expects you to know these are yearly tests, not one-time tests. For high blood pressure, after you start or change an angiotensin-converting enzyme inhibitor or a diuretic, recheck kidney function and potassium within a few weeks. A small rise in creatinine is acceptable, but watch for potassium that is too high or too low. Home blood pressure readings are valuable, and the exam often rewards the answer that uses them. Here is our third practice question. A 62-year-old man with type 2 diabetes and high blood pressure has rising protein in the urine and a steadily falling kidney filtration rate over the past year. Even though his blood pressure and blood sugar are well controlled, his filtration rate is now about 28. What is the most appropriate next step? This is a classic referral question. Think about what that falling filtration rate and the rising protein are telling you. We will walk through it next. Let us break down this answer. First, spot the referral trigger. A kidney filtration rate that has fallen below 30 or rising protein in the urine despite good control is the classic signal to involve a kidney specialist early. The exam rewards timely referral that prepares the patient for advanced kidney care before a crisis happens. Now, the key distinction, stopping the angiotensin-converting enzyme inhibitor would remove a drug that actually protects the kidney, so that is wrong. Waiting a full year ignores a clear downward trend. Starting dialysis is not done on these numbers alone, without symptoms or other urgent indications. The correct answer is to refer to a kidney specialist. Here is a critical test-taking pearl about when to refer to a specialist, because the exam loves to hide a referral answer among tempting management choices. Send the patient to a kidney specialist for an advanced or quickly falling filtration rate, or for heavy protein in the urine. Send to an eye specialist for any sign of eye disease found on a dilated exam. Send to a foot or vascular specialist for ulcers or poor circulation. And send to an endocrine specialist when blood sugar stays uncontrolled despite several agents. The trick on exam day is to notice the threshold the question just crossed, such as a filtration rate below 30 or a new finding on an eye exam. When a finding is beyond routine primary care, the right answer is timely referral, not more waiting. Commit these triggers to memory. That wraps up our review of chronic disease management test-taking strategies for diabetes and high blood pressure. Remember to review the diabetes and high blood pressure chapters in your main board review book and your question bank. Focus on the goal setting, medication titration, the stepped approach to blood pressure, the yearly screening, and the referral triggers we covered today. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.